I was drawing up a couple of drugs that are very similar. I then wrote on the syringes, a piece of tape on a syringe, curved surface, writing in a hurry. And when I came to put the patient to sleep, I want you to breathe some oxygen for me from this mask. And then you're going to feel yourself getting a funny taste in your mouth. I got the order of those two syringes wrong. One was a syringe just to speed the patient's heart rate up a little bit. The other one was a syringe to paralyze the patient prior to the insertion of a tube into the windpipe. I suddenly had realized I'd injected a drug that was going to paralyze somebody who was otherwise awake. Fortunately, I had the drug to put them to sleep at hand. I picked it up and injected it straight away. But before that had a chance to work, I realized the patient was becoming paralyzed. Therefore, what I did at that time was just to talk to the patient, because I knew that in a few seconds my drug to put them to sleep was going to be working. And sure enough it did. They went off to sleep. I went to talk to the patient afterwards, and the patient had no memory whatsoever of this particular incident. But there is, at the time when it actually happens, the sort of cold horror of this type of thing. Oh my gosh, I've given the wrong drug. And then, at the same time as you've got that horror, actually trying to think, no, hang on, what do I got to do about it? And you may only have seconds to do something about it.
A routine drugs mix-up with no serious consequences. But it could have been very different. Kathy Ryan was working in a busy A&E department when she made a terrible mistake with the quantity of a powerful injection.
This case occurred when I was a junior in A&E about 12 years ago. A gentleman, elderly gentleman, but a fit, robust elderly gentleman, came in with a fracture, quite a nasty and obvious fracture. He didn't need much in the way of clinical know-how to realise, and he was in a lot of pain. And I wanted to relieve his pain before we got him x-rayed. And I was standing over him with a syringe of diamorphine, which is heroin, very strong painkiller, giving it into his vein. And I gave him slowly 5 milligrams, which is, a medium to generous dose. And then the porter came saying that he'd come to take the gentleman to x-ray. And in a moment's of complete mental blank, which I still shake my head in disbelief that I had, I just pushed in the rest of the diamorphine straight in and let them take him to x-ray.
Dr. Ryan had made a potentially fatal error. She had only meant to inject half of the syringe. The double dose of diamorphine would drastically slow down the patient's respiratory system and eventually stop him breathing altogether. It was only by chance that the patient didn't die.
Fortunately, he was processed through x-ray quickly. I mean, this was late at night, so he could have been left in a corridor. But he was brought back to the department, by which time his breathing had diminished to something like 2 a minute, and he was blue and, in serious danger. I felt frightened that he was going to die. Frightened that, I didn't really know what to do. I wasn't experienced particularly at handling very acutely ill patients at all, never mind something which I brought about. And I gave him a drug which reverses the effect of diamorphine, and he was fine. Once I realised he was safe, there was an element of relief in that. But then I felt, very upset with myself, angry with myself, really disbelieving that I could have done something so stupid.
A doctor's life is made more complicated because drug packaging is often confusing.
These are the drugs that we might use during an anaesthetic. They're supposed to be stored out alphabetically, but immediately there are 2 problems here. Firstly, I can tell you some of these drugs are stored in the wrong place. And here, for example, we see 2 drugs, and I'll take them down from here. 2 drugs, similar names, Vasoxine and Valoid. Proper name of this is methoxamine. The proper name of this is cyclizine. So cyclizine C would be up there, methoxamine down there. But it's very easy when somebody's storing this cover just to take these boxes out, they read what they think, and they put the Vasoxine, which pushes your blood pressure up there. They put the anti-sickness medication down there. I come in a hurry, I reach for it, I read what I think should be Valoid up there, cyclizine for sickness, I reach for it, and I read it. I read again what I think I'm going to read. I take a syringe, draw it up, give it immediately to the patient who's being sick all over the place. But I've given the wrong drug, and it turns out that their blood pressure goes through the roof. So here then are two very simple problems that we have in every anaesthetic room in the country.
It's estimated that drug mix-ups account for 1/5 of all medical errors, which translates to as many as 8,000 deaths a year, all of them potentially preventable. But as drugs and healthcare both become more complex, finding a remedy to the problem will not be easy.
Medicine has become much more complicated. It's no longer just one person treating you, one doctor, your doctor. There's a whole team of people, all of whom have to work together. Also, many more invasive things are done, much more powerful drugs, much more complicated surgical interventions. And because of this, it's much more effective. But also, alongside that, if things don't go quite according to plan, then there's potential for harm in the patient.
So medical errors can occur for a number of reasons. Some of them obvious, like inexperience, fatigue and time pressure. Others are at the very core of medicine, like diagnosis and treatment. But whatever the reason, one thing is clear. The causes of medical errors are much more complex than simply blaming the doctor or nurse.